Okay, I think we'll get started. Good morning and welcome to Medical Genetics Grand Rounds, our first time in the bigger auditorium, so hopefully everybody has more room to spread out today. It's a pleasure to welcome back to Emory Bill Gahl from the NIH, where he's currently clinical director in the National Human Genome Research Institute. We were trying to guess or remember the last time Bill was here, and it predates my being here, so that's more than 8 years ago, so probably about 10 years. So it's certainly time to have him back and hear about his exciting new programs and activities at NIH. Most of you know Bill's longtime interest in metabolic disease and genetics, which, like a lot of geneticists, started very early in his career. In fact, as an undergraduate at MIT, when he studied with John Stanberry. For the younger people who don't know the name Stanberry, if you know the book Metabolic and Molecular Basis of Disease, the first iteration of that was Stanberry, followed by Stanberry, Weingarten, and Fredrickson. So it's gone through quite a successful evolution over time from the original Stanberry textbook. Bill did his undergraduate, as I said, at MIT Medical School back in Wisconsin, his home state, and then went to the NIH and was in fact the first medical genetics fellow in the intramural program at NIH, where he stayed throughout his career. Primarily for a long time at the National Institute of Child Health and Development, NICHD, and then moving over to the Genome Institute and taking over as clinical director of that institute. And today is going to... I also wanted to say, Meow circulated a nice article about the Undiagnosed Disease program that Bill has started and is going to talk about today, published in the NIH Record, that talks about Bill being part of the 3G network at NIH. The 3G network is John Gahl, the head of the Clinical Center, Steve Groft, the head of the Office of Rare Disease Research, and Bill Gahl, the head of the Undiagnosed Disease Program. So, Bill, welcome.
Thank you very much. Well, this is a program that has really sort of caught the interest of the nation. It's a program that takes patients who have no diagnosis and tries to find a diagnosis for them. And because patients have been through so much already, our success rate is very low. So I like to say that this is a program that has as its goal to fail, and we succeed in that most often. So I'm going to tell you something about our failures right here, some background, some numbers, some cases, some of the genetics, because at the NIH we have to do research as well as take care of patients. And then some evaluation. The genesis of this, that's a nice word, isn't it? The genesis of this, is from the interest on the part of the Office of Rare Disease Research, which was receiving calls from individuals who didn't have a diagnosis. And they're supposed to be receiving calls from patients who have rare diseases already diagnosed. So there was clearly a need on that front. In addition, the Institute directors had a retreat in 2007 in which they really wanted to harken back to their good old days. Because remember, Institute directors are going to be certainly in the second half-century club, and they were at the NIH in the 60s and 70s, so that's when the new fascinoma clinics were originated. So they wanted to revitalize the clinical center by a variety of things, and this was one of them. Our goals are to find a diagnosis for some patients, but also to discover new diseases and learn new things about pathways and physiology. And I think you'll see that we've succeeded a little bit in some of that. So the way that this works is that patients submit medical records and also a letter from their physician saying that the physician will follow up on this recommendations if there were an admission to the NIH. Then I triage the medical records, basically saying who among our experts should receive these records to look them over and try to help me decide whether to take these patients. We have a number of senior consultants who do those reviews, and then I come and synthesize it and make a decision, send out a letter. The patients who get to come here for about a week to the NIH, I should say. So On May 19th, 2008, Dr. Zerhouni presented this to the nation and through all this public relations. And incidentally, the public relations people don't want to call it public relations. They want to call it communications department, as if public relations were way too, let's say, pushy or something of that sort. Anyway, it got a lot of press, and so we were completely, basically swamped. And I liken this to Lucy without the chocolates. But we basically couldn't keep up. We were sort of screwed. Okay, so the UDP numbers of the first 18 months are here. 2,600 increase, but they didn't all follow through by sending charts. So basically about probably closer to 1,100 medical records, able to reject many of them, and without too much gnashing of teeth. But some of them difficult to turn down. Maybe they can't travel, for example, or they have basically two serious problems. They're too acutely ill. 14 patients have died, in fact, and most of them without coming to the NIH. 3 who came to the NIH and then subsequently died. And then we accepted this many, and 230 or so, and then about 150 are already admitted. The others are waiting admission. And then we have sort of rolling consideration for maybe 100, 150 or so. A lot of neurological cases, not too much cardiac, for example. There's so much knowledge about how to look into somebody's heart. Many complex pediatric genetic cases, as you can sort of imagine. Our whole contingent involves about 10, 12 people or so. But because we draw upon these unpaid consultants at the NIH, people who are experts in this or that, who simply look at the charts for us gratis. And those consultants cover all these different types of disorders and more. So there's an advantage to being at the NIH for 28 years or so, because I know whom I can call on and who will get angry with me if I call on them. So we have meetings maybe once or twice a week to go over the extant charts and triage records. This is a typical meeting. Used to be in my office, now it's in a library up the way because we have more people. And we update the database. We ask for the slides and the images in cases in which they have not been submitted. So we're talking, we have the x-rays and the CTs and the MRIs and all that, and we have the path slides as well, which we submit to our path department. Then our consultants can look at them when we send off the letters. Twice a week we have a meeting twice a month with Dr. Tift, who's now taken over the pediatric portion of this and relieved me enormously, and she does roughly the same thing. And then we have an open meeting once a month in which we sort of brag in a way about the complexity of the cases, and we ask the consultants to chime in. And we show images. We have a radiologist there. We show pathology. We have several pathologists there. And then experts in all sorts of disorders. About 60, 65 people show up for that. And as I say, there's a genetic analysis too. Dr. Tom Markello has taken charge of this, doing basically million SNP arrays using Illumina chips and certain types of software which he had to adapt for this. And what this tells us is copy number variance and lack of heterozygosity. Sort of go into that a little bit. Single nucleotide polymorphisms are what are measured here. And when you have two polymorphisms, let's say two possibilities, you'll have the A allele and the B allele, and the less frequent one is called the B allele. And so all SNPs in a disomic state are either AA, BB, or AB. Now these SNPs are chosen because they're polymorphic, and they're chosen approximately every 3,000 bases or so. So when you have 3.2 billion bases, that means you'll have 1 million SNPs in this array. And the technology is fairly straightforward now. It's the software and the analysis that's really the difficult issue. So here is a plot of the intensity here for BB, AB, and AA. This is an intensity plot. And if you're monosomic and just have B, you'll have half the intensity, etc. So if you look at the relative intensity here, the log R ratio, where the ratio is of A to B, it's the log to the base 2 of that ratio, you can detect copy number variance. So this is 0, which would be basically the log of 1, or where A and B are equal. And here the intensity is so low, it's several logs below that. And this indicates a deletion involving 32 SNPs. And because all of these SNPs can be annotated to the human genome, you know where the genes are within that region. So in this case, the genes are in the region of this gene, this deletion is in the region of the cystinosis gene, and we know that there's a 57,257 base pair deletion that's very common in North Americans who have cystinosis. And in this case, of course, it's deleted in the homozygous state. So this will tell us about copy number variants, meaning single copy deletions, double copy deletions, and duplications. But another analysis involves the B allele frequency. So in this case, you're homozygous for A, and here homozygous for B, and here you're heterozygous. This is the centromere, which doesn't have the SNPs in it. So if you were to take, let me go back a minute, if you were to take just this central heterozygous plot, and each one of these, of course, is a SNP. Each one of if you take that plot from several different individuals from our program, and just show the heterozygous portion here. So each of these is a different person. And this is the centromere. Then you see a region here which has no heterozygosity, no AB. That means that this person is homozygous for either A or B, it doesn't matter. Homozygous in this region. It is lack of heterozygosity. And here's another region, for example. So you can detect these things. And here's a 22-year-old who came to our program who didn't know about this. He has consanguinity because he has many different regions of lack of heterozygosity. And in fact, the amount of this is about 3 to 4% of his entire genome, which places him in a second cousin relationship, or at least in a cumulative second cousin relationship. And, he didn't tell us that, but we knew. So, be careful. So now let me tell you about some cases. So we have different types of cases. Here's some mysteries. We haven't actually seen this woman yet, but this is the same woman as this. So she has this incredible segmental, painful, neuralgic swelling, and she has to keep the room at 57 degrees and blow a fan on her because it hurts her face so much. We don't know why this is, but we're going to see her and try to figure out why she has such segmental autonomic nervous system dysfunction. Here's a woman whom we did see, and about 5 years ago, she had a relatively nondescript rash, which she treated with UV radiation and retin-A. And after that, she developed these keratinic spikes all over her body, which caused her to have enormous amounts of pain because they're like needles and erosions. And this is her scalp. In fact, a close-up of her scalp is this right here. So all of that is keratin coming out of the hair shafts. And on pathology, you can see what it looks like. And the abnormal part of this, besides all the keratin that's formed, is that at the base there are proliferating cells that are producing this keratin. So one of our basic research projects could be to try to find out why this poor lady has this. She's contemplated suicide, in fact, because it's so painful for her. Then we get a large number of young individuals who have had tragic neurological outcomes. This is sort of all of our nightmares. A boy who was fine until age 6 and then developed neurological dysfunction turned out to have some white matter disease in the paraventricular area. And because of his dysfunction, he became steroid dependent, had a tracheostomy, and you can't take his trach out because he closes up and he has trouble breathing and he needs the steroids in the trach. Well, this is a fellow who's got a 16 megabase region of homozygosity here, what's shown here, whereas his parents here don't. That region of homozygosity is around the centromere, and there are 53 genes in it, some of which are involved in neural growth and development. And that allows us to have a hint as to where we might go to search for an autosomal recessive disorder. Because in a region of homozygosity, you now only need one mutation because it will be recapitulated on the other allele. And then here are a couple of siblings who have short stature, macrocephaly, some dysarthria, so they're developmentally somewhat delayed, but they have a relatively, we think, a unique phenotype. And as siblings, this provides us with some more genetic fodder to pursue what they might have through some of the techniques we use. Again, these are patients whom we don't know the cause of their disease. Here's a 4-year-old girl who has a type of cranioectodermal dysplasia that none of our consultants has seen before. She has a sister who is undergoing psychiatric care because the sister doesn't know why people make fun of her sister. She has some findings here in the nails of ectodermal dysplasia, as acanthosis nigricans. And she has some papilledema here related to the abundant growth and widening of the skull in the area of the optic foramina. So her optic nerve is being pinched here. And so that really is probably her most critical medical issue right now. 3-year-old girl with microcephaly, seizures, developmental delays, and they, again, pretty much nondescript, I would say. But this young lady has something that's reasonably unique that could serve as a clue. In addition to her developmental delays, she has liver disease involving the beginning of some bridging necrosis and some inflammatory cells here. But she also has a bile canaliculus that has a patent lumen. And apparently you're not supposed to have that. Apparently this is supposed to be a virtual space. And the reason that it's enlarged is because the cuboidal canalicular cells are swollen and allow for this opening to occur. And really that fits with the fact that she also has copper accumulation. Copper accumulation in a space never seen with other copper storage disorders like Wilson disease or immune childhood cirrhosis. In other words, in those disorders, copper's in zone 1, near the vasculature. In this disorder, copper's in zone 3, which is near the biliary canaliculus. This is never seen, according to the pathologists that we have discussed this with. And then a 2-year-old boy who has conjunctivitis and developmental problems. He's really just too thin and is reasonably miserable most of the time. And some children who have these different things. You know, this young lady stumped 10 doctors, and then she stumped us. So 20 doctors or whatever. But sort of interesting cases still that require us to pursue them with genetics and with some biochemistry. Then some cases in which we have, I would say, better clues still. This is a 21-year-old. This is the woman who was on the Today Show the other day, if you saw her. And she's fine until her maybe teenage years or so, in which time she has these nodules in her lung, here or so. And one of the nodules was biopsied. I'll show you a picture of what she's got. And then she has ascites. Ooh, there's some arrows here. Oop, there are no some arrows here. Okay, she has some ascites here. And, oh, this is the arrow. And then she's got a huge kidney compared to her other kidney because her ureter was kinked. So she has some sort of fibrotic connective tissue disorder that has this pathology. It's partly fibrotic and partly inflammatory. And this is from biopsies, not only in the places that I mentioned, like the lung, but also in her jaw, where she has growth in her pterygomaxillary sinus to such an extent that it's impinging upon her muscles. And so she has trismus and can only open her mouth to about 8 millimeters or so. So difficulty eating, some pain, taken care of by non-steroidal anti-inflammatories, which are more effective for her than morphine is. Speaking essentially to the fact that she has these abnormal cytokine patterns, both circulating and within the tissue that we removed from her sinus. So this is called angiolymphoid hyperplasia with eosinophilia, which essentially speaks to another issue about undiagnosed diseases, which is to say that undiagnosed to one person is diagnosed to another, or undiagnosed to one person is diagnosed to a pathologist, in a way. In other words, pathologists can often use descriptive histological terms as a diagnosis that probably isn't what we're after, completely, because we don't really know the pathogenesis of it. So we're looking into cytokines and how the cytokines and their receptors might be influenced by in this individual. Here's a young lady, well, at my age I would call this a young lady, who has thrombotic microangiopathy and pyogenic granulomas on her skin, and increased VEGF, so vascular endothelial growth factor, is a factor that circulates and is responsible for the maintenance of certain tissues in the body, especially the kidney. So that if you don't have that trophic influence, the kidney will will develop the pathology that I'll show you. This is the pathology, which is basically the glomeruli become destroyed. This causes hypertension and also renal disease, so glomerular dysfunction as well. And this is typical for the disorder in preeclampsia. So the disease, preeclampsia, is really due to the placenta producing antibodies to VEGF, and then there's no trophic influence on the kidney, and the patient has to be delivered. So this is why removal of the placenta, or namely delivery, cures preeclampsia. But this is a lady who has high circulating VEGF by assay. But what that sort of implies, though, is that the VEGF that we're measuring is really non-functional. So it could have an antibody or some inhibitor bound to it. Theoretically, there could be, I suppose, an abnormal receptor as well with increased production of VEGF by a feedback mechanism. Those are some things that we don't know about. Point being, though, that this is a very good clue as to what might be going on in this young lady. And on her glomeruli, where she's supposed to have these really nice foot processor or podocytes, she doesn't. Everything is messed up, and that explains her creatinine of about 3 or 4. This is the woman who was featured in the New York Times magazine, who has, for one thing, she has only one eye, so this is a false eye. At age 10, this was removed because she had bleeding of her retinal vessels. I still don't know exactly why they took out her eye, but they did. And she has nail problems as well, but she has the same type of thrombotic microangiopathy that the other woman had, and splitting of the basement membranes here, and some mesangial proliferation within the glomerulus. So I'm not really finished with this. This lady then subsequently had bleeding from her gut and needed transfusions repeatedly, and decided she wasn't going to do this anymore. And so on a Sunday, we talked with her, and she said, I'm going to stop treatment. And she died on Wednesday and had her body sent to us, so we were able to do a post-mortem. But it's not really easy to transport a body across from Oregon. Here's a 39-year-old male who was just in the hospital here for the second time or so, who was perfectly fine. In fact, was the dean of a community college in Ohio, and had this spastic paraparesis. Came to us with a diagnosis of leukoencephalopathy, and you can see progression of his disease, but the progression was much worse later, and boy, it's a little hard to see here, but he really has quite incredible atrophy. This is a fellow who does not really have leukoencephalopathy. He really has primary progressive multiple sclerosis because he has these oligoclonal bands within his CSF. And he has protein abnormalities as well. But he also has culture-positive EBV. And there really is an hypothesis that some types of primary progressive multiple sclerosis can have as their etiology a continuous EBV infection. So we treated him over the last 3 months with acyclovir, or actually vanciclovir, or something that's a little more modern than acyclovir. And he got worse rather than better. So really we're speaking to the question of whether it's an ongoing infection with the EBV or a single episode of EBV infection in which antibodies are created, and those antibodies cross-react with his white matter, and in fact that's probably what it is. So now the therapeutic intervention will be to hit him hard with anti-immunological agents, rituximab, maybe steroids even. So that's what our neurologists are working on. So let me tell you about some of the success stories here. So maybe we've seen 150 individuals. I think that all the patients that we've seen have been happy because we've paid attention to them. I guess that's what we want as human beings. I know I need a lot of that, that's why I brought my wife along. Mary, you want to say hello? On the other hand, she doesn't like attention. Sometimes she's mad at me. Okay, fine. So sometimes we're successful and sometimes we're not. In any event, most of the patients are really happy with having someone try to find out what's going on. But we have had some success in a few realms. Here, for example, there's a man who has spastic paraplegia, and we found he has SPG7 mutations. He, incidentally, is a relative of Catfish Hunter, who's, you know Catfish Hunter. How many people in the room know Catfish Hunter? Raise your hands. Yes, Dan. Every male and a few women. Okay. So, Hall of Fame pitcher, right? Okay. Who incidentally had a neurological disease as well. Of course, if you're a baseball player and you have a neurological disease, you know what you're going to say you have, right? It's always going to be ALS or Lou Gehrig's disease. And of course, that's what they said he had. But he may not have had ALS. In any event, let's go on to number 2. It's a man who has autosomal dominant leukodystrophy due to lamin B1 mutations. And remember, lamin B1 makes up the internuclear envelope and allows for chromosomes to anchor to that and to have some influence on transcription. Smith-Magenis syndrome due to an isolated RAI1 mutation. Usually these are deletions. Neuroaxonal dystrophy with spheroids. Several patients who didn't have the diagnosis of multiple sclerosis, but because we have very good inflammatory CNS disease experts at the NIH, we're able to have that diagnosis. And we have 2 individuals who, on LPs, have CSF that had either 0 or very low tetrahydrobiopterin. Really not suspected. And actually, people who do the spinal taps don't always measure for neurotransmitters and CSF. And both of these individuals are responding to Kuvan. It's a brand name for, which I'm probably not supposed to say, so let's cross out Kuvan and say tetrahydrobiopterin. And it really, when you see a neurotransmitter defect improve, it's pretty miraculous. Okay, so then here's quite a case. A 52-year-old woman was fine until 4 years or so before it started to develop these muscles. She's not working out. She's not taking steroids or other androgens. And yet, these are her paraspinal muscles or so. The neuroradiologist saw her CT scan of her head, and she has rectus muscles of her eye that are 3 times as big as normal. They're stunned. So all over, and you know, not too many people really can work out the rectus muscles of their eyes. I suppose some criminals do that, but maybe not the rest of us. Okay, so she had had a muscle biopsy which was normal about a year before we saw her. We repeated the muscle biopsy nonetheless and sent it to the AFIP and found that she's Congo red positive in the vessels of her muscle, shown here. And then there's thickening of the walls of the vessel here and an aggregate of protein here. So when you think of Congo red staining, it means amyloidosis. And when you think of amyloid, the first thing we think about would be multiple myeloma. So we did a bone marrow and showed that she had 10% plasma cells. So, and then later found that she has a lambda light chain clone. So she has multiple myeloma. And an interesting case about this is that she was referred from Duke by an endocrinologist who said, you know, in my 38 years I've never seen anything like this, and blah, blah, blah. And then she tried to get into the Mayo Clinic on 2 occasions. Was turned down both times. Perhaps, we think, because there wasn't really a specialist who was, I mean, what specialist takes care of rapidly expanding muscles? We thought this might be a myostatin defect, by the way. You know, at least I thought that, and of course I was completely wrong. But, which is, again, part of the failure here. But once she had the diagnosis of amyloidosis, we sent her to the world's expert, or the country's expert at least, who is at the Mayo Clinic. So that is absolutely the irony of this, that some people cannot get into specialty clinics because the specialist knows that there are 5 other specialties involved and can't manage all the other ones. So this program actually provides access to that. And once the diagnosis was made, she went to the Mayo and got her stem cell transplant and had a little rocky course for a while, but recently, about a month ago, sent us all like Christmas cards and said, you've basically given me my life back. Her muscles are, used to be very strained and painful, and now they're not. And she was this far away from death, really. I guess if this is like 4 months or 6 months or something, because she had involvement of her atria, but not her ventricles. And apparently, once the ventricles become involved, it's irreversible. So she's very happy, and basically one case like this can, keep it going with all the poor cases that you can get, and we really see some poor cases. Then this is a success with respect to a new disease. This is actually one family shown here that has 5 affected individuals. We saw 2 at a time, this one and this one. So who have calcification of their large vessels, so they're actually arteries, below the waist, largely. And so you can see here, I'll show you better later. But you can see that it's probably a third cousin relationship. And this is the calcium scan for the whole body. And if you subtract the bones, you see this. Basically, her vessels, outlined by all of this calcium, these are plain films. Okay, so, and actually, Sanjay Gupta showed this on CNN. It's, so Sanjay Gupta says, okay, Dr. Gahl, you go over there, and then they show him, and he says, now this is a bone. This is normal, okay? But this isn't supposed to be here. This is all calcium in a vessel. So, Sanjay Gupta is a very nice man, by the way, very, very nice man. But it's always fun to make fun of television personalities. So anyway, more X-rays. And we now have 3 different families.
He sometimes attends our grand rounds here.
That's right, he's in Atlanta. All clear. I should have thought of that. Anyway.
He's not on videocast, is he?
No.
Okay.
Hi, Sanjay. Very nice man. Okay. Again, the foot. But there's also some periarticular calcification in the small joints of the hands and feet, which you can see here reasonably well, I guess. So Tom looked at the B allele frequency for a region throughout the entire genome that would have homozygosity for the sibs, but not the parents. And he found only this region. That homozygosity region is fairly large. It has 92 genes in it. But we have a collaborator in Heart, Lung, and Blood who had actually done her thesis on this, Cindy St. Hilaire, in Dr. Bohn's lab. And this particular enzyme, encoded by this gene, then became a candidate for being deficient in this. It's a 5' nucleosidase associated with the vascular endothelium of large vessels. And the expression is shown here, that gene, NT5E. It's low compared to the controls. The amount of protein produced is low in the affected compared to the controls. The amount of enzyme activity is virtually 0 compared to the controls. And the person has a homozygous nonsense mutation. Another family from Italy has a homozygous missense mutation, which is a pretty good one. And then we have another family of actually Bob Nussbaum, who saw our poster in Hawaii and said, I got a family like that. And that family has this particular mutation in compound heterozygosity with another splice site mutation that actually, no, it's a single deletion or something like that. Anyway, it's a frame shift. So in vitro, you can grow the cells, the fibroblasts, and also the vascular endothelial cells, and put them into a very calcifying medium. And if you do that for normals, after 17 days, you get nothing. If you do that for the affected, this is the amount of calcium that's produced by those cells. So there's a cell-centric defect here, and that defect is right here in the conversion of AMP to adenosine by this enzyme here. Now, it's already known that there's another disorder called infantile calcification or something that I hadn't heard of before, but I see you nodding, so you know about this. Maybe like 10 cases in the world or something, real rare. That is this enzyme defect, ATP to AMP. An interesting thing is that in this case, they considered that it was lack of the pyrophosphate that was causing the problem. Because pyrophosphate is anti-calcification. It impedes calcification. But in our case, we're actually converting AMP to adenosine, and it's most likely an adenosine deficiency that's really causing this issue. So I'll show you why. Because adenosine has 4 different types of receptors on the vascular endothelium. And apparently adenosine suppresses the natural calcification process, or the transcription array within cells. So ordinarily, there are all sorts of inhibitory forces that prevent calcification. And if you take away any of those inhibitory forces, you will have calcification. So the default is calcifying these cells. So adenosine signals for intracellular cyclic AMP to determine the amount of calcium influx and calcification. And in fact, this is really mediated through alkaline phosphatase and pyrophosphate. Okay, so some SNP studies. Just to mention to you that when Tom Markella took 47 individuals from the UDP program and 47 controls, and we did these million SNP arrays on them and determined the copy number of 0, 1, or 3, essentially the regions, the number of regions, the number of SNPs, and the sizes were essentially the same. So our patients do not have more copy number variants than you and I do. And I guess people sort of knew that we all carry a certain number of deletions in us. Usually they're not in the coding region, so they don't give us any problem. The coding region of the human genome is only 1.7% of the entire 3.2 billion bases, so it encompasses about 60 million bases or so. But there was a difference in the regions of homozygosity in our patients. So in order to determine what is abnormal homozygosity, you have to determine it for that particular region, because all of our different haplotypes have different degrees of crossing over, and therefore different degrees of natural heterozygosity here. So we have to determine what that background is. So I just mentioned this. So there's anomalous continuous homozygosity is what you'd like to determine. What is anomalous and what is really just background. So you have to determine the upper length of homozygosity within an individual region. So Tom divided up the 3.2 billion bases into 3,000 1 million base pair groups. So now for every million bases in a row, what is the threshold for runs of homozygosity there? And the way he did it was to do this. He determined the log-log slope of the frequency versus length. So for example, if the size is 1 to 10 SNPs in a row, then you might have thousands, 20,000 or so. 10 to 20, only 2,000. By the time you get up to 100 SNPs or so, you really should have 0. Well, you can plot this size here and frequency in a log-log graph and determine the slope of this. And there's a slope that's unique for every 1 million base pair region. That slope helps you determine the threshold in the following fashion. You can see that steeper slopes would be related to more crossovers and more gradual slopes to fewer crossovers. So the way that he determined the threshold was to determine the frequency at an arbitrary length. In other words, the frequency in this case at 2,000 kilobase length, and divide that by the slope. So when you do that, you're going to get a length. That length is the threshold for each 1 megabase interval. And so here, for each of these 1 million base intervals, is the threshold here. This is the centromere. So these are all those thresholds for chromosome 5. And if you do this for chromosome 14 and look at just control individuals, so these are not our diseased patients at all, it's like all of us, and you put a circle on for every person, then you have a few that are above the threshold, a little bit. And if you do the same thing for our patients, you get, again, a few that are above the threshold. So this does not differentiate well our patients from the controls. But it does filter out a lot of the homozygosity stretches, a huge amount. so that you can concentrate on the ones that are truly abnormal. Now, an example of a different chromosome, chromosome 11, is here. And this illustrates that these X's here will indeed detect regions of homozygosity that are visible on the B allele frequency plots by eye. So these are now regions of interest because they're so far above the thresholds for this particular region. And in fact, if you put it all together and look at all let's say the number of regions above the threshold for our controls and our patients, you'll see that if you use as a cutoff more than one threshold, you get 638 for the controls and 753 for the patients. Not too big a difference. But if you go down to 3 thresholds, you get 9 for the controls and 26 for the patients. So there are larger, bigger runs of homozygosity in our patients. Of course, you're going to say, well, of course that's true because probably you selected some of these patients based upon the fact that there were 2 affected individuals and the parents weren't affected or things of that sort, and they're clearly recessive types of disorders. And granted, that's true, but it really doesn't mitigate the value of considering runs of homozygosity when looking for clues for these autosomal recessive-based disorders. And in fact, this can be verified by examining individuals, let's say runs of homozygosity, when those individuals are products of consanguineous marriages, and where we know the homozygosity because we know that there's second cousin or first cousin once removed or whatever. And if you plot that against the measured regions by what I just mentioned, by the anomalous continuous homozygosity, there's a linear relationship with a correlation coefficient of 0.91. So this, we think, works. So larger regions of interest could be due to uniparental disomy, loss of heterozygosity, identity by descent, etc. We're going to get better at this. And we found some very good genetic leads in this fashion, and they help us to focus our whole genome and whole exome sequencing, which I'll just mention briefly in a little bit. We can also find mosaicism for aneuploidy in UDP using the SNP arrays. So this here is a region of mosaicism because you can see that the AB is no longer there, and instead you have AAB or this would be ABB or AAB here. This widening is an indication of aneuploidy because, see, this is the BBA and BAA, et cetera, et cetera. So when you see that bubble, you know that there's some mosaicism for aneuploidy. And here's that was actually on the X chromosome, but this is this is the X chromosome. So you see all these B allele frequencies look reasonably normal, but then you get to here, the X chromosome, and this is no longer in the center. It's also it's shifted, and this is for a male who, in this case, has this particular one where there's a shift too, but it's almost imperceptible because it's just a widening of the B allele frequency in the heterozygous region there. So, different degrees of mosaicism, large amount of mosaicism, less and less. Well, maybe this is actually control. So, and if you were to plot this on sort of a bar graph, you see the normal is in red here. That would be the normal frequency, but if you're mosaic, you're going to have like this for your B allele plots. And if you're wider apart, it's going to be, the mosaicism is going to be demonstrated out here. So what's causing the splitting? Well, one could be diploid and the other triploid, or one could be diploid and the other monoploid, but the combination of the two, the diploid and either triploidy or monoploidy, can give you exactly the correct B allele frequency, which is defined as one as F, and then 1 minus F is the fraction of the normal cells. So there are formulas for this. I wouldn't go through the formulas, but you can determine what the degree of mosaicism is using these formulas, and this would be for monosomy and disomy, and you can determine it empirically from an analysis of the SNP array, and I'm going to show you how that can be done. So if you have raw data here, which is, and actually this is designed through other disciplines, radio frequencies and things like that. Basically, when you have two Gaussian distributions and you want to determine if they are really two and how close you can get with those two distributions to determine a difference, well, this is essentially that. Only we have 1 million points and other people have only had like thousands of points in the past. You create a cumulative distribution function, which essentially determines the intensity and ranks these intensities. And you'll get something like this, which is really a plot of this, using a rank position. So, if you take, let's say, control here, then you have this, and you have this in the cumulative distribution function. If you have mosaicism with a little bit of mosaicism, some small degree, you'll have the two bands, and then this will have a little bit of a kink in it. And if it's mosaicism to a high degree, it'll have a huge kink in it, like that, in the cumulative distribution function. Now, you can determine how much mosaicism there is by following a model. And that model involves basically taking some examples and seeing which example your real data fits. So you take half the data from a normal B allele plot, calculate the distribution function, duplicate the function, and shift the values, half the values up one increment, and half the values down that same increment. And you essentially do this in an iterative fashion to determine which one's going to match best. Then you resort all the combined points into a new combine and fit the data to the best fit. So I'm going to show you how that works. So here's one of the best models for mosaicism for X would be to take a male and the male's mother, because basically all the diploidy should be the same, and the mosaicism should be contributed then by the son. So here's a 20 to 80 ratio, and this is the SNP array analysis, real data. So and it's all duplicated, 3 different copies of the B allele heterozygosity plots. Then you convert this into the cumulative distribution function, and you get this with a little kink in it. And it's really, so that's not exactly what you'd see for just diploidy. Then you superimpose this on the actual dizygous B allele plot, basically for the mother. Mother's in red now. And you shift these values up and down by 3 different deltas. In other words, 14.5% mosaicism, 18.5%, and 22.5%. So you're splitting these things half up and half down. And you can see that these, let's say, these are up farther than these are. You know, because it's 22%. Then you make this into a cumulative distribution function, like so, and you see which one fits best, based upon how many residuals there are. And in this case, you can sort of see the red is overlapping, red is overlapping. Here it's not overlapping. This is the fewest number of residuals. Therefore, you're matching this to 18.5% of mosaicism. And a computer can do this with 18.4%, 18.6%. In other words, the iterative function is so often that you'll get exactly what this fits, and you have 1 million points, etc. So you can determine the percentage of mosaicism involved in this. And we did that with different mixes. And I think it's really sort of neat that when we mix 20% to get 20% mosaicism, and we determined by the SNP analysis that it was 18.5%, that the error was not in the 18.5%, it was in the pipetting. You know, this is a pipetting error. This is not a SNP error. So that impresses me. Okay, so 4% is here. Okay, so just to sort of wind up some evaluation here. Patients are pleased. We saw some cases, new cases. Bring specialists together. We had a surgery conference the other day with Steve Rosenberg, who's really sort of a tough guy. He was incredibly gracious, engaged, interested. Surgeons were interested in a case that we had with in protein-losing enteropathy. You know, they had cut out 10 centimeters of our patient's jejunum and were analyzing it, and really engaged. It was inspiring. Yeah, and bolsters protocols, okay, never mind. So not so good. Triage, well, we get letters. We get letters from Congress people. The Congress people generally write letters before the patient is applied. You know, the patients think they're going to have some special treatment. Get letters from the administration. Don't like those letters. Still, I haven't budged. And you know what happens when I say, go through the process? They go above me. They go to John Gahl, the director of the clinical center, and then he gets some other sucker to take on these cases. So it works out okay. Huge numbers of cases. We're a little behind. For every big case, we have to see a lot, and there are a lot of patients who have a lot of complaints with no objective findings, and that's sort of irritating. We'd like to create a basic research arm and have actually engaged in this so far. The seahorse measures oxygen consumption in cultured fibroblasts and can give us a pretty good hint as to whether or not there's mitochondrial disease. We're looking for lysosomal storage diseases in some of our patients and can do even subcellular fractionation and analysis, even with mass spec. Immunohistochemistry on tissue slides, cytokines, keratinocyte culturing, that woman who had the spikes, looking to do that, fibroblast lemon B, one analysis, and now whole exome sequencing, which we've done on 23 individuals so far. The SNP analysis costs me about $450, but that's not counting the analysis, in other words, the personnel involved. The whole exome sequencing costs me $7,500 right now because we have access to the NIH intramural sequencing core. It's going to come down, but maybe only to a half or a third or something of that sort. Point is, this is a program that could tell us when we should use whole exome sequencing or how valuable it is, and under what circumstances, we think. And then candidate sequencing and whole genome sequencing will be done, I think, quite sparingly. Model for personal, I mentioned that. We would like to engage our intramural basic scientists in the UDP cases, which is a little bit difficult, and consult international experts and expand the protocol to possibly university centers through CTSAs. So, what have I learned? To fulfill our mission, we have to admit the patients essentially to my service. Because when I tried to admit them to extant protocols around the NIH, it didn't take long for people to start calling me up. Saying, this is taking way too much of our time. We're focused on this disease, etc. Your patients are, get out of my face is roughly what some of them said. And with very good reason. I really think they're absolutely right. They have young investigators, tenure track and fellows, and who essentially have to make their name in a particular field and can't be going off taking like 10% chances 5 times with cases that completely consume them for weeks. So they're absolutely right. This is not a model for advancement of young professionals. On the other hand, the guy whom we gave the calcification case to is, I submitted to the New England Journal, and he's probably going to get tenure based on that. So occasionally you can strike it rich. These patients would not come to the NIH without this program. I mean, who's going to take a woman who's got big muscles? That's not their field. They don't actually, a PhD could take it, but she couldn't actually take care of the patient. So, I've mentioned all that. And I would just, maybe what I'll do is, do you want me to stop now? I was on, this was on CNN online or something like that, and they talked about the comparison to House, which wasn't my idea. So some guy writes me an email saying, I saw the CNN thing, you need to get a grip on reality and get over yourself. I said of House, he sees acute cases and solves them right away. We see chronic cases and don't often solve them. Plus, Dr. House is not a nice guy. I guess I actually said that. So, this is television. Ever heard of it? It makes television watchable. No one wants to see paint dry on TV. And no one wants to see you not solving a case. Thank you for reaffirming my theory that doctors are morons. Just like you. Thank you, sir. Okay, but more seriously, I get these letters. And I get letters from schizophrenics, which are, at the same time, both incredibly pathetic and amusing, unfortunately. But never mind. So, I'm writing on behalf of my wife. She's devastated physically and has lost use of her remaining 3 fingers on her left hand. She's being treated regularly for depression, has frequent bouts of panic attacks. because she's totally helpless in her heartland in her room. She suffered more than I believe is humanly tolerable, but astoundingly, Anna's still here. It's almost as though she's died, and I get to talk to her from time to time. It's a battle advocating for her. She can't fight for herself. She can't cry. She says everything with her eyes. I feel totally powerless to help her. She desperately needs to find the cause of her condition. And when we called him up for, the husband up for more information, he informed us that she had died. Then the final letter is, my name is so-and-so, I'm 26 years old. On June 23rd, 2006, my whole world changed. I stayed with a friend the night before and vomited blood. The next day I got worse, and the slight touch to my skin would cause excruciating pain. Over the next 9 days, I went to the ER 13 times, but I was only treated for nausea. On July 4th, I went to the ER, and they did a spinal tap, and they said there were white blood cells in there that was a very high count. Thanksgiving 2006, I was life-flighted to the hospital. I was tested and was being treated and broadly diagnosed as having mixed connective tissue disease. She went to different hospitals, and they labeled her a hypochondriac or frequent flyer, which is a slang for a druggie. So now when I cannot stop and must seek help from the ER, they make me wait 7 to 12 hours to be seen by a doctor, even while I'm filling my bucket up, and where many times I'm also in severe pain sitting in the waiting room in a wheelchair while dropping oxygen levels. They've gone so far as to tell my mother, if we can't get her to stop, you'll have to take her to Utah because we're not admitting her tonight. I can't say in words just how hurtful this makes me feel. And when we called her dad up, she had also died. So we have patients who are at a very extensive level of desperation. And here's a guy who a few years before this, about 3-4 years before this, was completely normal, functional, had been a surfer, weightlifter, and all sorts of stuff. And he lost all of those neurological abilities, had dysarthria, couldn't speak properly. And our clinicians, our neurologists, said, he might have autosomal dominant leukodystrophy, which has recently been determined to be due to a duplication here because you make too much lamin B, and apparently that interferes with the nuclear infrastructure. So, and his main concern in life was for his daughter, who was, I think, 10 or some such, because he didn't want her to not only get this, but to be stigmatized by the fact that she might get this. So the family isolated themselves, stopped seeing their relatives, didn't have anyone over, wouldn't let the girl's friends come over because they were hiding him, the man. So a certain amount of pathology there. And when Tom did the SNP array, he found that he does indeed have a duplication in this area that is causal to this medical problem. And so his daughter is now at 50% risk, and it would be our duty to tell the family that he has this disorder. We won't be telling the girl this, and we won't be testing her. But the wife doesn't want to come. So there's an incredible amount of denial here, and this is becoming a real sort of social problem. But it really does speak to the issue of the desperation that we live in our human lives. And the hope of this program, which is to make people stronger after they've been broken by some of these disorders. Thank you very much.
We have time for a few questions, comments.
Maybe you, Steve.
Raise your hand and we'll try to get a microphone to you. Steve?
So early on you said there was a large number of patients that you didn't ask to come in. Is that because you came up with a diagnosis, or what were the reasons why you would not accept a patient?
No, we seldom come up with a diagnosis in those cases. Just a small percentage of the time we figure they haven't been worked up properly. But mainly it's because they don't have a good clue. And a large portion of these patients have a lot of complaints without objective findings too, and that's the lack of the good clue. But I'm sure that you know these patients, the ones that you would reject from your practice. But we're looking for things that can also not just provide a clue so we can have a diagnosis, but be insightful for us. So like new disease type things. So even if there's not a great clue, we can always rely upon our genetic analysis But if we think that it's something that hasn't been seen before and has a large constellation of unique findings, we'll go for that too.
Throw the microphone.
So basically, you would be accepting families with undiagnosed diseases.
Well, families, the question is, do we accept families? And families always help. In other words, when they're too affected, it helps us to know that we have a chance genetically. So, but maybe only 5% or 10% or so of all the patients we accept have more than one affected in them. But when we do see a patient, even adults, we often try to get the parents' DNA so that we can do the proper comparisons, not only by the SNPs, but through the whole exome sequencing if we decide to do that.
I would actually imagine there would be a lot of patients coming from the genetics clinics where we really don't know what this is.
Well, we see that, and we don't exactly need more patients. But I also think that genetics clinics are the exact ones because they've already screened us so well. They screen so well for us. So if genetics clinic were to select the cases that have a clue or have a family or have a very unique constellation of findings, that would be an incredible service to me, who, for the adults, for example, have to go through people who have, I have to eliminate an 85-year-old woman in a nursing home who's got a hematoma on her thigh. I mean, what kind of junk is that? So it's screening. That would be fine.
One more question.
Hi, I'm a geneticist from Canada, and I just wondered if you see Canadian patients.
Yes.
All right. Thank you very much, Gahl.